Coming on to clinic practice, so it's not uncommon to see antihistamines, cough syrups, nebulization, and I mentioned oral steroids as well for respiratory infections in infants and young children. So we all know that there is no role for these. We know that symptomatic treatment with nasal saline, keeping the room comfortable, hydrating the baby, supporting the feeding should be enough to recover, and monitor the baby for signs that indicate you may have a risk of bacterial infection and so on. But there is pressure to treat. The family has seen other physicians treating their children with these medications. They think if it's a baby, you need to give medicines to treat. And all the more reason you should avoid, because we are having reports from different countries where there are deaths from using cough syrups and so on. And in India, it's banned currently, thankfully, for under 4 years. So such measures are very important to discourage practitioners to avoid medications. Antihistamines have no role because it only dries your secretions. It's a placebo treatment. You give just saline spray and educate the parents. So the 2 or 3 minutes you spend in reassuring them that this is self-resolving, explain the danger signs well, and most of the parents will understand, and tell them that even if you have given this before, you can consider not doing it. And it's often prescribed, and there is also a risk of harm, especially with steroids or with the systemic, the nasal decongestants. It's very important to avoid using them because they can cause rhythm disturbances and so on. Even the nebulized medicines like salbutamol cause tachycardia and agitation in the babies. It's not needed unless you have a clear evidence that it's needed. It's very common to see in UAE, for example, diclofenac is used, and in India, I think mefenamic acid is very common. These are potent non-steroidal anti-inflammatory drugs. They're not really meant to be used for fever. Fever is something that's self-resolving, which you use the basic medications. You can use sponging if needed, make the baby comfortable. Again, the threshold for treating fever, making the parents alarmed when it reaches 39 is not really needed. So educate them that fever is part of the viral infection, and again, using a suppository or injection to treat fever is not necessary as well. So again, proper education becomes important. We need to either prepare leaflets or spend time educating them, or you can employ a nurse who is well versed with these things, who can spend time educating the parents, so you can avoid excessive treatment. In terms of diarrheal illnesses, there should be focus on oral hydration, which is what all the guidelines would say. But unfortunately, it's easier for us to admit and give IV, even if the child is suitable for oral treatment. And again, the type of ORS that's used is important. There are many sports drinks which are marketed as ORS. Very clear documentation is needed because they come in the ORS section of the pharmacy. The pharmacy may get a commission for selling those as well. So make sure you prescribe the right ORS composition for the type of diarrhea the patient has. And recently, Resveratrol has been prescribed for almost every diarrhea. It's meant to be used for secretory diarrhea, but again, even for milder diarrhea, and stool thickening agents and so on are not routinely indicated. Motility reducing agents are not routinely indicated. They may be potentially harmful. Seeing dysentery in an older child is not an indication to give antibiotics. You can observe them. If there is high fever or you think there is salmonella infection in the younger kid, you consider antibiotics. But in the older kids, dysentery just needs monitoring and testing the stool so you don't miss amoebiasis and so on. So antibiotic abuse is very common as well. And remember, antibiotic use itself leads to more diarrhea. So you may end up with more trouble because of that. And the people who spoke before me mentioned about the drug resistance and antibiotic overuse. Professor Sukumaran, Dr. Bala, Dr. Riaz, everyone mentioned that antibiotic overuse is a bane. So there is a room for improvement in all fields of medicine. Drug resistance is a huge menace. We don't have many options left. So we should minimize the exposure to antibiotics. And there are many studies coming out that shorter duration of treatments can be adequate. Of course, we have certain infections like group A streptococcus or something where you need a course, but in younger kids. But otherwise, when the child is symptomatically improving, it's reasonable unless it's definite sepsis or meningitis and so on, where you have to follow the regimented, where you are giving for the sake of your doubt, you can stop it earlier. And we need discipline in antibiotic prescription, and we should start focusing on this in the medical schools. It's very difficult to regulate its use in the community. In hospitals, you may have an antibiotic stewardship program where you need to justify whenever you go for a higher spectrum. But for a field like neonatology, for example, where in India, for example, the broad spectrum antibiotic resistance is very common, it becomes almost necessary to use a broad spectrum in a sick child. So how do you restrict the use in those cases? So the Answer is over the community-wide reduction, and obviously even in animal husbandry and so on, antibiotic use. So there are so many factors, and I'm not going to discuss all of that. But community education, discipline from all the practitioners, irrespective of what field they are in, and restrict the availability of antibiotics, especially the broader spectrum ones. This is one area where we shouldn't listen to the medical reps at all. There are medical reps who come, I cover cefixime, I cover broad spectrum cephalosporin. Please give at least 1 or 2 per week. So we keep listening to them, and subconsciously you start writing. Remember that broad spectrum cephalosporin should be restricted in their use to the essential patients. Now, even cefepime or the 4th generation cephalosporins are widely used. Never listen to the medical reps request for antibiotics, because you have a bigger responsibility to the whole community. UTI diagnosis on bag sample, all of us know that it is not going to be reliable. You end up over treating, because sometimes you have colonization with the ESBL as well. The bag sample can be used for routine analysis, but if the routine is abnormal, you always ask for a clean cat sample, or you may do a catheter or a suprapubic if the child is admitted. So never take a bag sample unless it's only for routine. Don't do a culture on that. And RSV positive bronchiolitis often get antibiotics or bronchodilators, which again should be strongly discouraged. I mean, there are guidelines from all bodies on RSV bronchiolitis, but because these are young infants and there is other guideline for young infants which tells you to be aggressive with them, we start worrying about it. Of course, we have the IAP guideline on fever management in babies 21 days and above. Please go through that. It does give you more options to show restraint